Okay, we're going to get started, and this is the Translational Research in Clinical Oncology course. In the government, you always have to have an abbreviation, so we call it TRACO for short. And we've been doing this now for about 13 years. And my name is Terry Moody, and my office is up at the Shady Grove facility. So that's on the way to Frederick, and we videocast this video conference live to Frederick. NCI, it's a big place, and about a quarter of our fellows are up at Frederick. So we welcome them watching on the videocast. So our organizing committee, I'd especially like to thank Jonathan Weiss for supporting this course financially. It costs us money to do the videocast. And generally, this is Monday afternoons 4 to 6, with two exceptions today, because yesterday was Labor Day, a holiday, and the other Monday holiday is October 12th. So we don't have class that day. We have class on Tuesday, October 13th. And so what we try to do is we try to have a PhD, such as myself, lecture with a medical doctor, such as Dr. Choiki, who will be lecturing at 5, to give you sort of both perspectives from cancer, both the basic perspective and the clinical perspective. We try to look at current treatments and see where the field is going. So every year we're always changing things and adding different lectures. So Dr. Choiki, his specialty is tumor imaging. He'll be lecturing at 5. Next week, one of the lectures is on epidemiology by Dr. Caporoso. And a big new area in cancer research is using immune checkpoint inhibitors. So for certain types of cancer, my specialty is lung cancer. It's basically hidden from the immune system. But using these immune checkpoint inhibitors, then the disguise of the lung cancer is taken off. So then, using the immune checkpoint inhibitors, then your immune system can attack the lung cancer cells. And so the immune checkpoint inhibitors, they're currently approved for melanoma, and there's clinical trials in other types of cancer, such as lung cancer, and it looks to be quite promising in this area. So at NCI, we not only do basic research, we do a lot of clinical trials. And here in Bethesda, we do phase 1 and phase 2 clinical trials. NCI, we have over 100 clinical trials going on in Building 10 at any given time. An area that developed a lot in the 2000s was using small molecule inhibitors of receptor tyrosine kinases to treat cancer. So Dr. Simeonov will be talking about this. And then as we get into October, we'll talk about topoisomerase with Dr. Pommier, and topoisomerase inhibitors are traditional chemotherapeutic drugs. Another way to treat cancer is using radiation oncology. We'll have Dr. Nichols talking about that. With cancer, as with many diseases, there's cancer health disparities, and African Americans, the women are especially more prone to breast cancer than our Caucasian women. Dr. Ryan will be discussing this. And then for cancer, one theory is that any cancer has a certain number of stem cells, and these stem cells are highly resistant to treatment with traditional chemotherapeutic drugs. Another thing is cancer results not only from mutations, but also epigenetic phenomena, whereby gene expression can be altered by acetylation of the chromatin and methylation of the DNA. So Dr. Verma will be talking about that. And then a new initiative by President Obama is precision medicine. And basically, we've been doing this at NCI for many years, whereby you do a genetic profile of the patient's tumor, and then this in turn dictates the treatment that the patient gets in the clinic. So all of this sequencing is done using the next generation sequencing. And finally, we discuss nanotechnology. So this is a new way to deliver drugs to cancer patients. And the hope is it will make the drugs more effective and cause less toxic side effects. So the course is open to anyone free of charge. You just have to register at the website. Registration actually closed last week, so if any of you want to register, you just send me an email and I can send you a form so that you can enroll in the course. And then a unique feature of this course relative to an academic course is you can visit tumor boards and core facilities at the NCI. So in late September, I'll have a list of various things that you can go and see, and this is all voluntary. If you don't want to do it, you don't have to, but it gives you an opportunity to see how the patients are discussed in terms of their treatment at the clinical boards, and to see the core facilities at NCI. We have a lot of them. We're a big organization and we have very big cores. And then finally, if you want to get a certificate of completion for the course, you have to take a final exam. This is a multiple guess exam, and there's 26 questions, one question from each of the lectures, and you take this online at the website, and you have up to a month to take the exam and pass it, and then you will get your certificate. Are there any questions on the organization of the course? Okay, if not, then we'll proceed. So with cancer, you see each year we have over 1 million new cases in the U.S., and there's over 500,000 deaths. The big four are lung cancer, colon cancer, breast cancer, and prostate cancer. Each of these has about 150,000 new cases each year. But then when you look at the mortality, these cancers cause about half of the mortality as well, but the mortality is very differently distributed. Lung cancer is extremely difficult to treat. So therefore, 90% of the people who get it will die from it, and usually that death is within 2 years. Colon cancer is better to treat, but where we've really made advances is in breast cancer and prostate cancer, especially breast cancer. We see we have over 200,000 women getting it, and about 20% or so are actually dying from it. And what's going on is the mortality in breast cancer is actually declining because the treatment's getting so good. We have antibodies such as Herceptin to treat it. We have aromatase inhibitors to treat it. So there's lots of drugs that are available. With lung cancer now, we're just starting to find a few things that are working. And what we find that's working is tyrosine kinase inhibitors and these immune checkpoint inhibitors show even greater promise. So with lung cancer, the number of deaths has actually leveled off. And one of the primary reasons for that is there's less smoking going on in the U.S. But in other countries, such as China, they're smoking more. So in China, you expect a big increase in lung cancer in about 20 years. And so the Chinese have approached the U.S. to talk about this problem and what can be done. So other cancers that kill 10 to 30,000 annually are listed here. Pancreatic cancer is very difficult to treat. This will be lectured on by Dr. Hussain later on in the course. Another cancer that's very difficult to treat is ovarian cancer. This will be lectured on by Dr. Annunziata later on in the course. And then brain cancer, especially glioblastoma, is very difficult to treat. So there's still a lot of work to be done in terms of cancer and its treatment. So, what are the cancer risks? Well, drinking alcohol, this facilitates liver cancer. So if you drink a little alcohol, that's good. If you drink too much, you can get liver cancer, and that's bad. Asbestos, that causes mesothelioma of the lung. And asbestos was used as an insulation product in the 1980s in this country. And even NIH has some old buildings that have asbestos in the walls. So as long as the walls are covered up and no one is doing construction on them, you're fine. But if you start seeing dust in the air, look out. Diet. So a lot of Asians eat pickled food. And as a result, in China, you see a high incidence of stomach cancer. Familial, genetic. Some cancers are genetic, such as breast cancer. Women who have BRCA1 or BRCA2 mutations are at high risk for getting breast cancer. And similarly, in colon cancer, there are genetic components. Hormones come into play, especially in the female cancers, the breast cancer, and the ovarian cancer. Estrogen is a hormone that can facilitate tumor growth. In men, you have progesterone, which can facilitate the growth of prostate cancer. A big problem now throughout the world is obesity. People are eating too much and putting on weight, and this leads to a higher risk of getting cancer, especially colon cancer. Psionic radiation, such as the atomic bombs that were used in Japan. Many people died from leukemia initially from the psionic radiation. Tobacco. People who smoke tobacco get lung cancer, but oddly enough, only 1 out of 6 tobacco smokers will actually die from lung cancer. Many of them will die from other things, such as heart disease. UV radiation. What's happening in the world is our ozone shield is getting depleted, and as a result, there's more UV radiation. This leads to melanoma. And so in the U.S., melanoma is going up in the southern states, especially Florida and Arizona. And then viruses increase your risk of cancer, especially HPV virus leads to cervical cancer. John Schiller will be talking about this later on in the course. So my specialty is lung cancer. We're going to use this as our first model. And so with lung cancer, we have 45 million current smokers, but the good news is there's 45 million ex-smokers in the US. Now, when you stop smoking, your heart recovers very fast, but your risk for getting lung cancer, it takes about 10 years after you quit smoking to get back down to normal risk. So the carcinogens in your body, they build up and they stay there for a while. And it's very difficult to quit smoking due to the nicotine addiction. The nicotine is in the cigarettes, and that's the primary component that makes smoking a pleasurable experience. So a carcinogen that we'll be focusing on is the polyaromatic hydrocarbons, abbreviated PAH for short. Another carcinogen in tobacco smoke, cigarette smoke, is NNK, which is a metabolite of nicotine. Another bad thing is ethyl carbamate. This is what you use. It's varnish for your floors in your house. And then there's heavy metals that could be very bad, such as chromium, arsenic. Hydrazine is basically rocket fuel. So the cigarettes have lots of bad things in them. But initially, you have precursors, such as the benzapyrene is a precursor for the ultimate carcinogen, which is BPDE. So the benzapyrene gets metabolized by enzymes to the carcinogen, BPDE. And then this carcinogen, which has an epoxide in it, can react especially with guanines in the DNA, leading to mutations. And the genes for P53 and KRAS are frequently mutated in lung cancer. So here you see benzapyrene. It's a organic metabolite, lots of benzene rings, and then it gets hydroxylated by the enzymes, and then an epoxide actually forms right here, which then interacts with the guanine of the DNA. So you see we have the benzapyrene, and these P450 enzymes metabolize it first to 7,8-oxide, then 7,8-diol, and then we get the BPDE, which interacts with the guanine on the DNA, ultimately leading to mutations. And so the P450 enzymes activate the carcinogen by adding oxygen, but then phase 2 enzymes convert the oxygenated carcinogen to a form that is highly soluble in the water so that it can be excreted. So the DNA gets mutated if the rate of carcinogen activation exceeds the rate of carcinogen detoxification and or DNA repair. So with lung cancer, it takes about 20 to 25 years of smoking to ultimately lead to cancer. And P53 is a tumor suppressor gene. What it does is it mediates G1 to S phase checkpoint of the cell cycle. So in the S phase, the DNA replicates, and the P53 keeps the DNA from being replicated. But when it gets damaged, then you get greater replication of the DNA, and the mutated DNA in particular, leading to the process of carcinogenesis. So generally P53 leads to programmed cell death, so that the cells that are starting to get mutated will die. But when P53 is mutated, these mutated cells will then live. And another thing that goes along with the P53 mutations is P21 expression. And P21, when it's overexpressed, it inhibits the G1 to S transition. When it's mutated, then again, you have the cancer cells readily going into the S phase of growth. So when P53 is active, it induces the expression of BAX, leading to apoptosis, GAD45, DNA repair, and thrombospondin, which inhibits angiogenesis of the tumors. So with P53, it's not a random site mutation. There are certain places where the P53 gets mutated, such as exon 5, exon 7, and exon 8. And here we see a chart of percent of point mutations, and we see at position 157 and 158, there's lots of mutations. At position 245, 248, 249, there's lots of P53 mutations. And at position 273, there's P53 mutations. So when P53 is mutated, then the cells rapidly go from G1 to S phase. In S phase, we get the DNA replication. In the G2 phase, we have to go over a checkpoint to get to the M phase. And in the M phase, the chromosomes get segregated, and we go from an adult cell to 2 daughter cells. And in cancer research, basically we've made lots of cell lines from tumors, and these cell lines grow very rapidly, and they go from adult to daughter cells within 24 hours. So every day, the cancer cell will duplicate. So P53 mediates the G1 to S phase checkpoint of the cell cycle. DNA damage increases P21 and P53. P53 drives programmed cell death or apoptosis after DNA damage. So when your P53 gets mutated, it's very bad. For the cell cycle, we have two major enzymes participating in it, the cyclin-dependent kinases and the cyclins. So in the cyclin D1 is very important in growth, and it's sort of considered an oncogene. When we go from the G1 to S phase, we have CDK2, cyclin-dependent kinase 2, playing a prominent role, but its partner changes. In the G1 phase, its partner is cyclic E. In the S phase, its partner is cyclic A. Then in the G2 phase, the partner for cyclic A changes from CDK2 to CDK1. And then when we go to the M phase, the CDK1 interacts with cyclin B to process the segregation of the chromosomes. So the cyclin-dependent kinases, we have lots of inhibitors, P21, P27, P57, P15, P16, P18, and P19. So you see there's so many cyclins involved and so many cyclin-dependent kinases involved and inhibitors involved. So this is a very important component in the cells, the regulation of proliferation. In cancer cells, they're programmed to grow as fast as they can. That's what they want to do. So in terms of tobacco smoke, after 10 years of smoking, cells start to change and they become hyperplastic or metaplastic. After 15 years, there's further progression to dysplasia. All of these processes, hyperplasia, metaplasia, and dysplasia, are reversible if you stop smoking. But then after 20 years, a cluster of tumor cells will form, a carcinoma. And then after 25 years, a malignant cancer can form, and this process is not reversible. So for lung cancer, it's thought that over this 25-year period, dozens of genes get mutated. But the question is, what's the driver mutation? What are the key mutations for the cancer versus what are the passenger mutations? You want to focus on the driver mutations. So here we see in a normal cell, everything's fine, but then with hyperplasia, the cell number starts to increase. The cells are growing. And then with dysplasia, the cells become disorganized. Cancer cells will stack up on one another, whereas normal cells, you have contact inhibition. With further mutations, you get a carcinoma in situ. So lung cancer, it starts in the lung, but then the cancer can undergo metastasis to other organs. And with lung cancer, it undergoes metastasis to the liver, the lymph nodes, the brain, and the bone, especially the spinal cord. So here we see a normal lung, and we see these villi on the surface. And when you take a breath, you breathe in O2, and you exhale CO2. So this is what your breathing is all about. But in carcinogenesis, we see we've lost the villi. There aren't very many villi left. And we see the number of cells has increased dramatically. The blue are the nuclei of the cells, the pink is the cytoplasm. So this is hyperplasia. Now with dysplasia, we get disorganization of the cells. And with a carcinoma, such as an adenoma, you get a group of cells. But if you have cancer at this stage and you know it, you just have a surgeon go in and remove that group of cells. But if the cancer progresses to an adenocarcinoma, this is malignant, and now this can undergo metastasis all over your body, and it's not the primary cancer that kills you, it's the metastasis. So here's another look at it where we have the normal cells. We start getting mutation of tumor suppressor genes like P53 or oncogenes such as the EGF receptor. And so the cancer gets initiated. And then growth factors promote the growth of these carcinoma type cells. So then when you get enough growth, then you get the malignant cells forming, shown in red. And these cells in red can then undergo metastasis to other organs. So with tumors, they start from a very few cells getting mutated, then a carcinoma forms, and as the tumor gets bigger, it needs to be able to get access to oxygen and growth factors. And so what it does is it has the host provide blood vessels to the center of the tumor. And so these blood vessels, through the process of angiogenesis, then deliver oxygen and nutrients so the tumor can get bigger. And then when it gets bigger, some cells can slough off and undergo migration to other organs and metastasis. So we mentioned P53, it's a tumor suppressor gene. That gets mutated, but also you can have silencing of genes, such as P16 and the retinoblastoma gene. You don't have to have mutations. You can get other phenomena going on, such as methylation of the genes. And then with oncogenes, you can get amplifications and or mutations. So we mentioned cyclin D1 is in the cell cycle. c-MYC is a nuclear oncogene that gets expressed when the EGF receptor gets activated. And then ERBB2 is also overexpressed, especially in breast cancer. And there's an antibody, Herceptin, that's very effective in treating women with ERBB2 positive tumors. For the EGF receptor in lung cancer, it gets mutated, and we found that we have tyrosine kinase inhibitors that are effective in lung cancer. So these show you then the receptor tyrosine kinases, the EGF receptor. It's a big protein, over 1,000 amino acids. And the EGF binds to domain 1 and 3, shown in green. In the yellow, these are structural domains, the cysteine-rich domains. And then when the EGF gets mutated, the receptor dimerizes and turns on the tyrosine kinase domain on the intracellular side. And then this can phosphorylate protein substrates, starting the growth cycle. So the IGF-1 receptor is similar to the EGF receptor, except that it binds insulin, not epidermal growth factor. And this is a dimer. The EGF receptor, structurally, it's a monomer. And then also some of the tyrosine kinase receptors have these immunoglobulin domains, such as the FGF receptor and the VEGF receptor. This is very important in angiogenesis. So in terms of ligands, the EGF receptor, or it's called the ERBB1 receptor, or HER1 receptor, has many ligands such as EGF, The lung cancer cells that I work with, they especially make TGF alpha, transforming growth factor alpha, which binds to the EGF receptor. And curiously, there's also ERBB2 receptors on lung cancer cells, or HER2, new, but there's no ligand for this. But the way it gets phosphorylated is the EGF receptor can form homodimers with itself, or it can form a heterodimer with HER2, causing the phosphorylation of HER2. So the EGF receptor, it's big, 621 amino acid extracellular domain. Domains 1 and 3 bind the growth factor. Domains 2 and 4 are enriched in cysteine amino acids. There is one transmembrane domain, 24 amino acids, and then a 541 amino acid intracellular domain that has tyrosine kinase activity. And in particular, the lysine at 721 binds ATP. And the ATP is then transferred to tyrosine amino acids on protein substrates. In addition, the EGF receptor can tyrosine phosphorylate itself at tyrosine 1068, 1086, 1148, and 1174. So the EGF receptor, it's been a big thing, especially in non-small cell lung cancer for the last 10 years. And all these tyrosine kinase inhibitors have been developed as drugs. And EGF binds with very high affinity, as does TGF alpha. And you can couple the TGF alpha to cytotoxic entities, such as the Pseudomonas exotoxin 38, and it binds with high affinity and will then kill the cancer cells. So this is work that's done on by Ira Paston of NCI. And when you add EGF, you see the EGF receptor gets strongly tyrosine phosphorylated. It's at 180 kilodaltons. Also, you see substrates like phospholipase C gamma at 148 gets tyrosine phosphorylated. And here's PA3 kinase getting tyrosine phosphorylated. And this phosphorylation is reversed by the tyrosine kinase inhibitors, gefitinib or erlotinib. So these tyrosine kinase inhibitors, they basically fit into the binding site so that the ATP can't get in. And if the ATP can't get in to the EGF receptor, the substrates can't get phosphorylated. So in lung cancer, it was found that certain amino acids get phosphorylated, get mutated, such as the leucine at 858 gets converted to a arginine, or the glycine at 719 gets converted to a cysteine. And this then increases the affinity of the receptor for gefitinib or erlotinib. They're small molecule tyrosine kinase inhibitors. They block the ATP binding site. So here you see the gene, actually a schematic of the EGF receptor. Here's the tyrosine kinase domain, and you can get mutations at amino acid 858 or 719, and this affects the sensitivity then to erlotinib. So if you're doing molecular medicine, you go into the tumor, you do a genetic analysis. If you see that the 1719 position is mutated or the 858 position is mutated, you know gefitinib or erlotinib are going to work in that patient. So this is what molecular medicine is all about. So the EGF receptor, we mentioned that there's what's called signal transduction pathways by which it stimulates growth. And ultimately what happens is this protein called ERK1/2 gets phosphorylated, goes into the nucleus, and turns on expression of certain genes, such as CFOS and CJUN, which trigger the growth. So the TGF alpha binds to the EGF receptor. It can tyrosine phosphorylate itself, or HER2. Then it interacts with these adapter proteins and goes through the RAS, RAF, MEK, ERK pathway to stimulate growth. And in the EGF receptor, we have mutations in about 15% of the lung cancer patients, but KRAS also gets mutated in about 20% of the patients. So KRAS is an oncogene. When it gets turned on, it stimulates growth. So KRAS gets mutated, especially at codon 12, and in Frederick, there's a big research program initiative using RAS as a molecular target. So they're trying to come up with new ways to affect mutated RAS to inhibit cancer growth. So downstream from RAF is a serine threonine kinase called RAF. When it gets mutated, the valine at 600 to a glutamate, the patients become responsive to a tyrosine kinase inhibitor. So about 60% of the melanoma patients get mutated BRAF, and then they respond to this drug, PLX 4032. So both RAS and BRAF are considered driver mutations in cancer. They're important. And then MEK is a protein kinase. It will phosphorylate ERK. And there are MEK inhibitors as well that are being used in the clinic, such as selumetinib. And we mentioned ERK goes into the nucleus, causing the expression of nuclear oncogenes such as FOS, JUN, or MYC. So here's a cartoon where we see the EGF binds, causes a homodimerization to form, activating RAS, which activates RAF, which activates MEK, which activates ERK, which goes into the nucleus and alters oncogene expression, leading to increased proliferation. And this is a cartoon showing the crystal structure of the EGF receptor. And when I first saw this 5 years ago, it sort of blew my mind. But here you see a monomer. We have domains 1, which binds EGF, and domain 3. Domain 2 and 4 are the cysteine-rich domains. And they dimerize and form an inactive dimer. And then they sort of twist around another when EGF binds, causing a conformation change, turning on the tyrosine kinase activity. And so when the EGF receptor gets activated, another pathway it can go through is the PI3 kinase AKT-mTOR pathway, stimulating cellular survival. So the cancer cells don't want to undergo apoptosis. They want to stop apoptosis and continue to grow. And so the apoptosis goes through PI3 kinase, then through AKT, then through mTOR. And PI3 kinase can be mutated in breast cancer, glioblastoma, colon cancer, and stomach cancer, resulting in a gain of enzymatic activity. So this will increase survival when the PI3 kinase gets mutated. PTEN is an enzyme which inhibits the activation of the PI3 kinase, but PTEN is mutated in about 13% of the breast cancer patients. And when PTEN is inhibited, then there's more tyrosine phosphorylation, there's more survival. And AKT, there's really very little mutation of AKT. people are trying to develop drugs for AKT and mTOR to use in terms of cancer treatment, but there's a long ways to go. And this one's a little hard to see, but this is sort of one of the protocols that was present here at NCI for treating lung cancer patients, whereby you biopsy the tumor, and if it has an EGF receptor mutation, then the patient gets treated with erlotinib. If it doesn't have an EGF receptor mutation, you look for RAS, RAF, and MEK mutations. If it has that, you then use a MEK inhibitor to treat the patient. If it doesn't have a RAS, RAF, or MEK mutation, then you look for PTEN, PI3 kinase, and AKT mutations. If it has that mutation, you use a PI3 kinase inhibitor on the patient. If it doesn't, you look for ERBB2 mutations. If it has ERBB2 mutations, the patient gets treated with lapatinib. If it doesn't, you look for KIT and PDGF mutations. If it has that, you treat with the tyrosine kinase inhibitor sunitinib. And if it doesn't, you just sort of progress and use traditional chemotherapy on the patient. So this is the area of molecular medicine that I was discussing. You look for mutations, and if you find a mutation, that in turn dictates the treatment of the patient. But for the tyrosine kinase inhibitors, initially they worked really good. And then after a year, they found they weren't working so good on the patients. And it was because the tumor had undergone further mutations of the EGF receptor. And now in half of the patients, there is this T790M mutation of the EGF receptor. And so erlotinib and gefitinib no longer work. So you have to come up with something else for the patient. So the chemists are synthesizing second generation EGF receptor inhibitors, third generation EGF receptor inhibitors, and it goes on and on. So the point is, cancer is a moving target. You get something that works, that's great, but you got to keep your eye out because the cancer could then mutate into something else. And then you've got to basically start over again. So another example for tyrosine kinase inhibitors is CML patients. These are patients with leukemia. So you get an excess proliferation of white cells in the blood. And it was found that this Gleevec, it was the first tyrosine kinase inhibitor that proved useful in patients. And with CML patients, they don't have mutations, they have a translocation. And segments of chromosome 9 and chromosome 22 get fused, generating what's called the BCR-ABL gene. In this gene, the tyrosine kinase activity is constitutively active. So here we see on chromosome 22 and chromosome 9, there is a break point and then a translocation. And we get a fused BCR-ABL protein. And the pathologists first were able to determine this because when you look at the chromosomes, you see if there's this translocation, chromosome 9 gets bigger, and chromosome 22, which has BCR-ABL, gets smaller. So this was before molecular medicine and all the sequence analysis of the human genome was known. And so the toxicity of the Gleevec was nausea, vomiting, edema, and rash, nothing life-threatening. And after a year, 53 of 54 patients responded. And over a 5-year period, 89% of the patients had no evidence of cancer whatsoever. And here again, we see that the Gleevec blocks the binding of the ATP to the tyrosine kinase. But after 5 years, they started finding some resistance again. And they found that the mutation was a point mutation. The threonine at position 315 was replaced by an isoleucine. So then second generation tyrosine kinase inhibitors were developed, such as ponatinib and DCC-236. So again, it's evidence of the cancer mutating into something else. So the cancers are very smart. They want to keep growing. And the scientists, we think we're smart, but we have to keep working because the cancer can outsmart us. So with CML, we mentioned imatinib. Gleevec was used initially. Now dasatinib is a second generation inhibitor. For breast cancer, we have Herceptin, which is a monoclonal antibody, and lapatinib, which is a tyrosine kinase inhibitor. For melanoma, we have BRAF as the molecular target. PLX4032 is effective. This gastrointestinal stromal tissue has a receptor tyrosine kinase called c-KIT, but it was found that imatinib works on the c-KIT tyrosine kinase as well as the BCR-ABL, and the sunitinib is the second generation inhibitor. And for the lung cancer, we have gefitinib and erlotinib as first generation tyrosine kinase inhibitors. And now, how are we going to prevent cancer from developing? So a real big area in cancer is chemoprevention. How can we stop the cancer from forming? And well, one of the things I learned when I moved to Maryland is check your house for radon. Radon causes lung cancer, and a lot of the rocks in this area have radon in them. So I moved out to the country, a house on a hill, and when I went to sell the house, they said, well, we can't sell it because you have too much radon in your basement. You have so much radon that it would be the equivalent of smoking 2 packs of cigarettes a day had you lived down there. Well, we lived on the main floor, so that was fortunate. But then to sell the house, we had to put in a pump. And the pump basically just puts air in the basement so that the radon gets flushed out. You want to check your house for asbestos. We mentioned before that asbestos in the walls can cause mesothelioma of the lung. And unfortunately, even at NIH, many of the buildings, the older buildings, still have this asbestos in the walls. You want to check your community system for water. You want to drink good water. You don't want to breathe polluted air. I was a graduate student in Caltech at Los Angeles. So I was there for 5 years, and every day around 1 o'clock, my lungs would start hurting from the ozone. The ozone would come through Pasadena every day around 1 o'clock, and you just feel your lungs burning up. They said for every 2 years you lived in Pasadena, you would lose 1 year of your life. I don't know if that's true or not, but I said, well, I'm going to go to NIH when I graduate. Here in DC is not that bad. We have a lot of wind. It just blows it out to the ocean. Okay, protect your skin. So we mentioned about the UV exposure in Arizona. You don't want to get melanoma. So when I go outside and I like to garden, I always put on sunscreen so I tan and not burn. You don't want to breathe smoke, polluted air. This can lead to lung cancer. You want to exercise daily. I'm really into exercising. I do a lot of bicycling. And this Saturday, I'm supposed to ride in what's called the Civil War Century, 100 miles of riding through the countryside of Maryland and Pennsylvania. Avoid pesticides. These can lead to prostate cancer. Eat lots of fruits and vegetables. They have antioxidants. We mentioned The chemicals have to be oxidized to become carcinogens. So if you have antioxidants, that's good. You want to reduce red meat consumption, don't eat as much fat, eat fish. They have omega-3 fatty acids. Minimize fried foods. Drink alcohol in moderation. Avoid unnecessary x-rays and reduce infections. We mentioned before that cervical cancer comes from the HPV virus. And finally, we have some references. And that's the conclusion of my lecture. So are there any questions? Yes.
So can I just ask about those so do they actually grow regression of non-cancer? They stop the flow? I didn't quite get that.
Well, they can reduce the tumor size, and in general, they make the patient feel better, but they don't really cure the cancer. Yes, you have to keep taking it once you get on the drug. But in contrast now with the immune checkpoint inhibitors, they actually improve survival. So that's what you're really looking for, is a reduction in tumor size, but as well a dramatic increase in survival. Yes?
Are there studies combining immune checkpoint inhibitors with tyrosine kinase inhibitors?
Not yet, but that's a good idea. No, in general, when you test the new drugs, the FDA mandates that you have to test each drug separately. And then once they're proven safe separately, then it's possible to combine them. But what's going on basically is if people, when they become resistant to the tyrosine kinase inhibitors, now they're trying to put these patients on the immune checkpoint inhibitors. Okay, we have Pete. You want to load your presentation or just use the one you sent me?
I didn't make any changes.
Okay.
So Terry, is that in one day?
Takes about 8 hours.
Let me introduce them.
Okay, so this is Pete Choike. He's the program director of the molecular imaging program. He got his MD from Jefferson Medical College. He did his residency at Yale New Haven Hospital. And following an internship at Pennsylvania, he joined the faculty of Georgetown. And then in 2004, we were very fortunate to recruit him here. Pete.
Thank you, Terry. I'm still trying to recover from your 100-mile ride on Saturday. That's great. Well, let's see. My name's Pete Choike. I'm a radiologist in the National Cancer Institute. And what I'd like to do today is sort of give you a virtual tour of a radiology department, talk about what's in it, what kind of equipment, how it works, what are some new developments, and how we image cancer. So as you can see, there are a variety of different machines that kind of look the same. They all have an area where the imaging takes place and a bed or a gantry where the patient sits. So we'll talk about that. Now, we use imaging in cancer for a variety of reasons. First, for screening. There's mammography for breast cancer. There's recently approved by Medicare CT scans for lung cancer in smokers. And so that's a way to detect cancer at its earliest time before it's spread and has obvious implications for survival. Then once a cancer is detected by other means, an important role of imaging is staging. And staging divides into three categories, the T, N, M parts of cancer. So T meaning the local parts or topology of the cancer. N meaning whether there's nodal involvement, and M meaning whether there's distant metastases. That's the TNM classification that's used around the world. And imaging is very important to understanding how far the cancer has spread or metastasized. Then, once all that's done, the patient is treated in some way, and imaging is used serially to monitor patients to see whether their cancer is responding, growing, recurring. And then, of course, in the same vein is recurrence. That is, even after the patient's been treated, and the cancer apparently goes away, patients are brought back periodically so that if the tumor does recur at a later time, it can be treated appropriately. So has it come back? And sometimes imaging is just obtained to give an overall estimation of what the patient's prognosis is, whether the amount of tumor is so great that there's no real reason to pursue therapy, or whether there's a modest amount of cancer that really warrants therapy. So that's prognosis. The main devices that I'm going to talk about today are computed tomography, or CT, magnetic resonance imaging, or MRI, ultrasound, single photon emission computed tomography, SPECT, and positron emission tomography, or PET. And we'll just say a few words at the end about optical imaging, which is not a traditional imaging technique found in most radiology departments. So as I alluded to in the beginning, if I were to quiz you on which scanner was which, I'd forgive you for not knowing which one is which, because superficially they all look the same. And frankly, as a board-certified radiologist, when I walk into a room, sometimes I don't even know what the machine is until I look at the very tight details of what's going on. The exception is ultrasound. Ultrasound, over here on the right, has a unique appearance, and we'll talk a little bit more about that. But the basic architecture of the imaging device found in a modern imaging department look very similar to each other. Now, we're not going to talk about plain old X-rays, because we assume that you guys have either intersected with that or it's so obvious that you wouldn't need to. And in any case, conventional X-rays really play a relatively minor role in the management of patients with cancer. We're mainly doing cross-sectional imaging, meaning we're taking axial or sagittal or coronal sections of the body and imaging it. So this is a perfect example. This is a CT scan of a patient with lung cancer. And you can see the tumor here, and behind the tumor, or distal to the tumor, there's an inflammation that won't heal because it's blocked by this tumor. So it's kind of a blocked infection that just persists over time. And there's some volume loss in the lung. So you learn a great deal just from a simple single slice through the chest. So this is the normal side lung, but you can even see a tiny nodule on the other side, indicating that this cancer may have already metastasized to the other side. These are the airways, and otherwise it's very difficult to see things the way this image is windowed. And we'll talk a little bit about that. So CT I'm going to talk about first, because it's really the most important of the techniques that we use in the department. It has the advantages of being very widely available. There's very minimal preparation, so this means the patient shouldn't eat anything before coming to the department for CT, and then they'll be asked to drink some contrast, oral contrast, to opacify the bowel. But other than that, there's very minimal preparation. It's very rapid. The machines that we have now in the radiology department can scan from essentially the lower neck to the pelvis in 2 to 3 seconds. So a single breath hold all the way through. The bed or gantry is so fast that the engineers have to install a brake in it to slow the patient down at the end. Otherwise, they found, fortunately in dummies, that the dummy slid off the table due to the deceleration. So we now have a very nice braking system in this, but it's an extremely rapid, I mean, incredibly rapid, with hundreds of images in just a second. And then it's very high resolution, and it's relatively inexpensive. And that's largely due to the throughput. You can obviously do patients very rapidly with these machines. And as a result, even though it costs over $1 million to buy a machine, you can see how it could be paid for very rapidly. There are a number of disadvantages to CT. The most obvious one is that it uses radiation. It often requires intravenous contrast media, which can have allergic reactions. It's very, very unusual, but it can happen. And in patients who already have some renal damage, the iodinated contrast media that we use for CT can cause further damage. So that's a risk in patients who have renal dysfunction. And ultimately, one of the disadvantages of CT is that it only provides you with anatomy, not anything about the function of what's going on, just the structure. Now, how does this work? And this applies also to plain radiography, but the basic setup is that you have a power source, a wire, going to a coil that burns off electrons, so that's the cathode, and it's attracted to the anode, which is positively charged. So these electrons go with quite a degree of force into this target. And you can see that it's an angled target. And it's just like any collision experiment. There's an interaction of these electrons with this target, the tungsten target, and X-rays come off in multiple directions. And those X-rays are directed towards the patient. Now, a very important aspect of this is if you just let this anode and cathode behave like that, you'd get X-rays all over the place. So one of the important things is to put a collimator here to guide the X-rays in a certain direction. So it blocks all the unwanted directions and just has the direction that you want toward the patient. So the patient lies on the table, the gantry being the part of the table that's inside the instrument, in this case the CT. And this X-ray tube with its anode and cathode generates these X-rays that go through the patient and to a ring of detectors that are completely circumferential around the patient. And as you can imagine, from this idea of CT projection or filtered back projection, as you take multiple views of these 4 tubes, you will get different profiles depending on where you are. So at one point at this diagonal, you'll see 3 bumps. At this perpendicular, just 2. Again, 3 as you go this way, and 2 as you go up and down. And as you do this more and more, you'll begin to recognize the 4 tubes that are in there. And this is called filtered back projection. Now, there are many, many sophisticated image processing algorithms that clean up this image significantly. But this is the basis for the imaging. One of the things that you can do is something called Fourier transform. So you can look at all these waveforms and perform what's known as a Fourier transform. And that can really clean up the image significantly. So as we get away from the cartoon and towards an actual model of a CT scanner, you'll find the CT source here with the X-ray fan beam coming down to the patient against the detector array, and then data acquisition systems all around this, because the amount of data pouring out of this is so fast that you have to have your acquisition systems right there to capture it all. Now, we talk about the spiral CT, and that's because the acquisition is occurring as the patient is moving on this table. And so in space, it prescribes a spiral around the patient. So the X-ray tube is moving, the patient is moving, so you get this kind of coil-like appearance or spiral-like appearance. And that's important because we think about CT scans as these individual slices. That's what we look at. But that's not really what they are. They're really volumes of data. And then they're retrospectively cut in the way that we see them. So we obtain it as a volume, and then we cut it. Well, that's important because now we can cut it in any plane that we want to. It's not just axial. It can be this way, sagittal, or this way, coronal. And that can be important for different cancers to look at better. So this is an example of how that volumetric CT can be used. So it's very common for me to be looking at the axial images, which turn out to be sort of the convention, the way we look at things. But then I'll see something, for instance, in the kidneys that bother me, and I'd like to take another look at it, like what is this little cystic area? And I'll put it in the coronal plane very quickly, and you can reassure yourself that it's really nothing. It's a normal variant. Now, if you have a question about what's going on in the bones, this sagittal view is clearly the best way to look at the spine, because you can see how each of the vertebral bodies is aligned and whether there's any compression fracture or evidence of metastasis or anything. So you can see how it's very useful to have this volume of CT. Now, one of the things that we're going to talk about in just a few minutes is how to reduce the amount of radiation exposure that patients receive during the CT. Keep in mind, this tube is on for 2 or 3 seconds, and it's going over the whole body. And, that's not a trivial exposure to radiation. Now, what people have figured out, though, is that the body has different densities at different parts. So in the lungs, there's relatively lower density than in the belly. And as you thin out to the pelvis, there's less density overall. And so you can modulate the amount of X-ray for the body part so that the shoulders, where there's lots of bone and soft tissue, might get a lot of relatively high amount of X-ray. The lungs could be dramatically dose reduced. And this can be adjusted to the size of the patient and can be done more or less real time as the patient's on the scanner. So this brings us to the issue of radiation. So this issue really came to the fore about 6 or 7 years ago in a very tragic case on the West Coast. It was a young patient who was getting a scan for trauma of the head, and the scan was set up. The child got the CT. The technologist was not attentive to what was going on, and it turned out, for whatever button the technologist had pushed, that the scan just kept going and going and going, and it was several minutes before they realized that the scan was just going on and on. And the child had a radiation burn on their scalp, and it was widely disseminated. Now it's, social media. It was just, it spread like wildfire. Within minutes, every radiology department in the United States knew about this tragedy. The child, by the way, has now been followed for 6 or 7 years. Nothing has happened, but obviously everybody at that hospital is going to hold their breath for the rest of this kid's life because of what could happen. But it caused an earthquake in the manufacturers. How is it that you could keep a CT scan going under any circumstances for 3 or 4 minutes? Why do you even have that feature? So that was eliminated. But people started to think, really, are we doing everything we can to reduce the amount of radiation that these scanners put out? For years, we were thinking about doing a pre-contrast scan, an early post-contrast scan, a late post-contrast scan, maybe even a delayed post-contrast scan. Radiation didn't enter into the picture. And now it's sort of, well, maybe we should be paying attention to this. And it's quite true now that engineers have gotten in on the game, we can dramatically improve the sensitivity of the detectors. We can use the modulation of the body size. There are all kinds of tricks of using dual energy, a high energy and a low energy beam, to dramatically reduce the amount of overall radioactivity. And so we have, we've been able to lower the amount of energy of the X-rays. The detectives are more sensitive. There's better reconstruction algorithms. There are even images that can be calculated from other images. So before, we had to take a scan before contrast to see a non-contrast scan. Now we can subtract out the iodine from the post-contrast scan and say this is what a pre-contrast scan would have looked like. So it's completely simulated, but the patient doesn't have to have that second scan. So as a result, there have been dramatic reductions in the amount of radiation. The second thing I want to talk about is this iodinated contrast media. It's extremely useful. This is a pre-contrast scan, and this is a post-contrast scan. And you barely make out this lesion. And here you can not only make it out, but characterize it as a cyst and of no consequence. So this is an extremely useful part of what we do. So in any CT scanner, what you'll find is not only the CT itself, but also a pump that injects the contrast and then flushes it with the second syringe that flushes saline through it. And typically we'll use some kind of iodinated contrast media. Now, one of the great inventions of the 20th century, in my estimation, was the invention of non-ionic iodinated contrast. When I first got started, the contrast was ionic, and it would be 2 or 3 times a week there would be a major allergic reaction to iodinated contrast. In the late 1980s, people developed non-ionic iodinated contrast. It came out of Norway, and it revolutionized the amount of allergic reactions, so that in the current department using iodinated contrast, it's maybe once a year that we have an allergic reaction. So it's very, very powerful. And the other concept that I want to leave you with on CT is how to window a CT. So one of the powers of CT is that you can take the same image and then window it in different ways to get different information. So for instance, you can get information from the heart on this window and the lungs on this window. We could do another window that would tell us about the bones, and you get dramatically more information by playing with that. So what we talk about with windowing is how broad the grayscale is. So this image is made up of potentially of different grayscales from white to black. If you limit the window to this, so that the darkest, I should say the lightest thing on this image will be sort of light gray, and the darkest will be dark gray, then you can get a very different image than if you have a window like this that extends all the way along the scale from very light gray to black. So I think these, the arrows may be a little confusing. They should be reversed. So with that, I'd like to move on to the second modality, which is MRI, magnetic resonance imaging, a very powerful technique. Here I'm illustrating a prostate MRI, where this is the prostate gland, and in the anterior part of this prostate is a tumor, and you can see the path specimen where you can see how well the tumor was depicted by the MRI. Although there are 2 smaller tumors that are not seen on the MRI, these are inconsequential. They're very, very low-grade areas and wouldn't have required treatment. So MRI has some distinct advantages. Unlike CT, there's no radiation involved, no ionizing radiation. It's directly multiplanar. You can scan in any direction that you want. And the most important thing is that it has multiple contrast types. So we talk in terms of T1 weighting, T2 weighting, diffusion weighting, contrast enhanced, spectroscopy. All of these provide different windows into the pathology that's inside the body. And so it becomes multi-parametric. You don't look at things just simply because of their X-ray attenuation. You look at them through their MR characteristics. Disadvantages. Well, it's considerably slower than CT. Remember we said we could get through the whole body in 2 to 3 seconds in CT. Not true in MR. It takes 15 minutes to a half an hour to get many CT MRIs. Some of the MRIs can be even longer. The machine is more expensive. The machine is slower. So the per scan cost is going to be higher. So it's more expensive. It doesn't depict things like calcifications, which is clearly a limitation for things like kidney stones. And there are some safety issues, very different than CT. The biggest ones are that ordinary objects outside of a magnetic scanner are harmless, but inside the MRI can become a lethal projectile. So we train very heavily on safety with MRI. And then there are a number of incompatible devices like pacemakers and cochlear implants that can't function or will be disrupted by being in a strong magnetic field. So we're going to do all of MR physics in about 5 minutes. Some would say that's all you need, but so this is going to be a rush job, but we'll see how it goes. What's the principle behind MRI? I hope after these 5 minutes you'll agree with me that it's amazing that it works. But here's how it works. You have protons mainly associated with water molecules, H2O, so there are 2 protons per every water molecule. We're filled with water, lots of protons. And as you sit here, they're wandering all over space in terms of their spin. They're directed randomly. Now, if you put them in a magnetic field, they will align with the magnetic field. They'll either go in the direction of the magnetic field or the opposite direction of the magnetic field. But either way, they're aligned with the magnetic field. Now, one of the pieces of magic is at a certain magnetic field, they have what's known as a resonance frequency. So they're spinning around their axis. They're not just aligned like a soldier. They're actually spinning. And the frequency that they're spinning around is the resonance frequency. And if you hit them with a radio frequency wave at that frequency, the resonance frequency, you can get them to do things. You can get them to do tricks, like deviate from their axis into another plane. You can get them to rotate all the way down to being in the opposite direction. Energy is absorbed. Good, because when energy is absorbed, it can be retrieved at a later time. So when you turn off your radio frequency at the resonance frequency, turn it off, as the spins start to return back, they give off radio frequency waves at the resonance frequency. So here we are applying the resonance frequency. We're shifting the spins down into another plane, and as it relaxes, it's going to give back signal. And this is the complex radio frequency pulses that are applied during an average MR sequence. So we're going to sort of stop there with the electrons and the spins and the protons because it's going to get, we don't really want to go down that street. We just want to know where it all comes from. Amazingly enough, from that property that I just described, a couple Nobel Prizes are in there, but from that, we are able to generate images. One of the tricks is to apply what's known as magnetic gradients across the body in sequence. And when you do that, you change the magnetic field at each point in the body, which means that you change the resonance frequency at each point, which means that when you excite with one resonance frequency, you're only exciting a certain part of the body, not everything. So the trick is to apply these magnetic gradients, increasing in strength as you go through, and you'll scan different parts of the body just by doing that. You'll steer what you're able to image just by applying a magnetic field to the patient. Very cool. Okay, now how do we get this all to actually work? So what we have in an MRI magnet, this is a cross section, is starting from the, you have a part that the patient experiences, sort of a plastic tube, and inside that are the coils that will not only generate the radio frequency that we're talking about, the resonance frequency, but also receive the signal that's coming back. So you have antennas that not only send out the signal, but also receives. So this is the, what's in this called the RF body coil. So that's sitting right there. Right behind that are the gradient coils. So remember I said to get spatial recognition, you need to apply these gradients, magnetic gradients, and so that's what comes next. And then there's an insulator, and then there's this space, which is super cooled to near absolute zero, and it has titanium wire in it, and through that, the magnet is charged up with a huge amount of energy. So when a magnet is commissioned, they come in with a generator and essentially apply a huge amount of energy to these superconducting wires. They fire up, and they're an electromagnet. So they generate a huge magnetic field that's steady, like a rock. And we have what's called the cold head, which allows that the liquid helium to surround this wire so that we're constantly at absolute zero in the outer layers of this magnet, so that we can keep it under vacuum with thermal insulation and keep it at supercooled so that we can keep this superconducting. And that's the basic anatomy. So once you put all the covers on, it looks like this, and it looks very much like a CT scan, you know, with a gantry and the table and the injector. Now, there's another thing here, the ear protection, because this is very loud. This process is very loud. You say, where's the noise coming from? Well, all this, the application of the gradients creates movement, just a little bit of movement in the coils that we're talking about. And that movement causes a vibration noise that's transmitted into the gantry. And it is very loud, so we have to have ear protection. Another thing that you always see in a CT, in an MRI, and it differentiates it from a CT. So when I walk into a room trying to decide, is that a CT or an MRI? You just look up here. Is there something going through the roof? That's an MRI, because that's the quench pipe. Here's a problem. Let's suppose that there's a short in that wire that we've just charged up with a lot of energy that makes our magnetic field. There's a short. Well, it burns, it creates heat, it vaporizes the liquid helium that's surrounding it, and all of a sudden you have this release of a tremendous amount of liquid helium being converted to gaseous helium. And you've got to get rid of that quickly, otherwise your room will fill up with liquid helium and not oxygen or air. And that means people in the room will suffocate. And I'm not kidding. That can happen. So what we do in every installation is have an emergency quench pipe that goes to the outside. And it's designed, it's a pipe basically, designed to take the helium, gas helium, and vent it outside very rapidly so it doesn't accumulate in the room. Now, a few words about MR safety. Ordinary objects that are ferromagnetic will be attracted at high speed to an MRI. And so even keys or scissors, any kind of tools, and of course mops and buckets can be sucked into a magnet. And people forget that even though the lights are off in an MRI scanner, everything's quiet, the magnet is still on, 24/7, 365. And so if you walk into a MRI room with metallic objects, they'll go right into the scanner. If a patient happens to be there, it could be a big problem. In fact, another tragic case that happened about 10 or 15 years ago was a patient who was a young patient again, who was getting, needed to be sedated for the MRI, and they were there with an anesthesiologist, and the anesthesiologist realized that the oxygen in the tube that he had in the room had run out, and he was very worried about the kid not having oxygen. So he yelled out, "I need oxygen, I need oxygen." Some helpful person came in with an oxygen tank that was not MR compatible, and it killed the child as a projectile. It was a torpedo that flew into the magnet. So safety is incredibly important. And in fact, there's and partly because of that, we design our MR facilities to have various zones. So these are safety zones. Zone 4 is where the magnet sits. Zone 3 is the control room for the magnet. So you can't even get into the control room unless you're checked or you're an employee. Zone 2 is where the patient is dressed. This is where the questioning takes place. Do you have metal objects? Do you have any implants, pacemakers, et cetera? And then there's reception, which is considered sort of a safe zone. But you see that you don't get access to the MRI directly. You have to go through a series of checks to make sure that everything is cool before you go in there. Otherwise, stuff like this can happen, like the buffer for the floor and a tool chest just gets in there. And there's the oxygen, not the one that caused the damage, but so. And finally, a word about MR contrast. So here's a tumor that's lighting up in the liver, and the only way you could see it was with the contrast. And what this is gadolinium-based contrast. So it turns out gadolinium by itself is a toxic element. If you just inject, for instance, gadolinium chloride into somebody, you'll cause a lot of problems. But if you attach it to a chelate, such as one of the ones shown here, you can very safely get the properties that you want, that is, relaxing the magnetic field, without the damage that free gadolinium can cause. So these are FDA-approved gadolinium reagents. Now, this is very topical and is something that's going on right now. There are a number of approved agents, and they have different chemical properties. But this is quite important, the thermodynamic stability constant. That's basically how tightly is that gadolinium bound to that chelate? What would it take to get it off? So a high number means you have to put a lot of energy to get it out. A low number means that it's not that hard to get it off. And these are measured in log scale. So between this agent and this agent, there's literally 10 to the 10 fold difference in the chelating ability of these two compounds. 10 to the 10. Well, that's interesting. A few years ago, it was reported that patients who had had multiple exposures to gadolinium and who had renal failure, so they weren't clearing the gadolinium as fast as other people, were getting these kind of rashes and strictures in their hands. They couldn't move their hands. And when it was biopsied, it was a kind of systemic sclerosis that was occurring. And it was tracked to free gadolinium that was coming off these chelates. Not all of the chelates, but the ones at the lower end of that thermodynamic scale. So it was first noticed in Denmark, May of 2006, 25 cases of this nephrogenic systemic sclerosis, and it was largely traced to this form of gadolinium contrast agents. And there were a number of other reports in 2006, and ultimately 200 cases were reported. But it became quite clear that if you switch to another gadolinium chelate, one with a higher thermodynamic stability, that you could essentially eliminate this side effect. And by 2013, there were no cases reported, and it's something that is something we screen for. We look for renal function. We use agents with high thermodynamic stability. And this is just an example, just to show you on this bone scan how much damage there is throughout the entire body due to this. So it's a very tragic thing. Gadolinium is very toxic, and although patients with normal renal function excrete gadolinium rapidly, patients with abnormal renal function may take weeks, and the gadolinium can dissociate from its chelate, leading to fairly high concentrations in the skin. And fibrosis is a reaction to that free gadolinium. So those are the risk factors. And but as I said, this is really pretty much eliminated as we got rid of these kind of scans and only reserved these agents for normal renal function. But very recently, within the last few months, people around the world have been noticing that patients without renal dysfunction have this brightening in the dentate nucleus and basal ganglia of their brain. And when they look back, they see that those are patients who have received multiple doses of gadolinium. Now, there are no known side effects from having this, but one could argue this isn't a good thing. So again, we have this list of agents, and it's quite clear that we need to start moving up this thermodynamic stability to the very best. So it's never been reported with this agent, Dotarem, or this agent, Multihance. And these are, the ones with a very high thermodynamic stability. So this is another example. All right, let's shift over to ultrasound. Again, ultrasound is something that's cool because no radiation, it's real time, it's inexpensive, it's quick, little prep, no injection. It has some disadvantages. It very much depends on the expertise of the person doing the scan. CT, as long as you can push the right set of buttons, you'll get a beautiful image. Ultrasound, not true. You really need expertise. It took me at least a year to get good at ultrasound. So another part of ultrasound is it's like a flashlight. You only see where you shine the flashlight. So if you don't look at a certain area, you won't see it. Unlike CT, it's like lighting up the whole room. Difficult to quantify, and there's limited access to some tissues like the lungs. The air in the lungs just reflects sound. You'll never see it. The bone surrounding the brain prevents sound from getting there. So you just have limitations for where you can use it. So the basics are pretty self-evident. You have a transmitter that sends sound in. It reflects off something, and you hear it back. Now, the medium through which it goes can change the speed of the sound, and you can measure that as a change in the time that you hear the echo. So in a slow tissue like water, it will take longer to get back versus condensed tissue like muscle, where the sound will return faster. And so you can get a characterization of tissue based on the speed of sound. When you send sound out into the body, you can get various things. One is attenuation. For instance, the skull will just attenuate the sound. It'll never get deeper. The sound can be absorbed without any reflection. That's unusual. They can be reflected. That's what we depend on. It can be scattered or refracted or even diffracted. So there are a number of artifacts. But this is a typical ultrasound in a patient with metastatic colon cancer. And you can see all these little echogenic foci representing the metastases. And they look a little brighter because they're reflecting the sound a little better than the normal liver tissue. So the anatomy of an ultrasound is this piezo electric block. It's a crystal that when you apply power to it, it will send out these alternating waves of sound. And these can come in all kinds of shapes and sizes and even frequencies. And one of the things that's going on in the field is how we're evolving from these fairly large machines that were certainly portable down to these handheld devices that are nothing more than tablets, or in this case, the size of a cell phone. In fact, there are applications on the iPhone to have an ultrasound transducer right into the power cord of the iPhone. One of the most important uses of ultrasound is in guiding biopsies. Because it's a real-time technique, you can identify the lesion and then put a needle into it to see what it's made out of. It's very helpful for guiding. And we've been using ultrasound microbubble contrast in a research setting to see how it helps. But traditionally, ultrasound is something that doesn't require intravenous contrast. So in the last few minutes, I want to get into the other part of the Department of Radiology, which is the radionuclide section. And here we're talking not so much about anatomy, but about function, about molecular imaging. So single photon emission computed tomography is a mouthful, but you have to understand that a radioactive nucleus can emit a variety of things. It can emit an alpha ray, which is a helium nucleus. It can emit a beta ray, which is essentially an electron, or it can emit a gamma photon, no mass, but what we call an X-ray or gamma ray. So if you have a substance that emits a gamma ray, that's a single photon emission. And you can combine it with the CT that we described earlier to get a SPECT CT device. Advantages of SPECT is that it's a relatively inexpensive technique and there's broad experience with it. The disadvantage is that it involves radiation and preparation of an imaging agent. It's subject to nuclear regulatory regulations, and it's a relatively slow, low-resolution method. So we won't spend all that much time with it. Very important to how it works is if you look at a radioactive, or if you imagine a radioactive nucleus emitting a gamma ray, it's a random event in terms of direction. It'll emit in any direction it feels like emitting. And if you're trying to get an image out of that, you need to tame that gamma ray by putting in front of it this lead collimator that only lets through X-rays of a certain dimension. Remember, we talked about this in CT. The CT anode-cathode ray tube was spreading X-rays all over the place. You don't want them all over the place. You want them just where you want them, so you put a collimator there. And very similarly, you put a collimator here in front of the detector so that only the parallel gamma rays are absorbed. But that makes it inefficient. So this is a picture of just such a collimator, and you can see these very tiny holes, and it's fairly thick. So you can imagine that unless you're dead on here, you're not going to get through that collimator. And then this is depicted here. So this gamma ray will get through, but these gamma rays will be deflected by the collimator. There's a problem here. And the problem is that the patient is absorbing all this radiation, right? It's the camera that we're kind of protecting here. And so it's very inefficient. Only less than 1% of the counts that are generated actually make it to the camera. So that's sort of a disadvantage. It's still very actively used, but it's sort of passé in the sense that we understand that it's an inefficient system. So it also requires the use of a radioactive isotope, usually to some compound of interest. So in this case, we use technetium-99m, which is a gamma emitter, single photon emitter, and we attach it to methyl diphosphonate that binds to bone. And suddenly we have a bone scan, which is a time-honored technique that we use for, say, prostate cancer. Now, you don't have all day to do this scan. There's a radioactive decay with a half-life of 6 hours. So by 24 hours, you're down here with the amount of activity. So you really need to scan in the first few hours after you've injected. So there are a variety of agents that will work here. MDP is a bone scan. Pertechnetate is good for looking at the thyroid and salivary glands. Thallium can be used for the parathyroid and the heart. Indium for white cell labeling. Iodine-131 for the thyroid. And here's an example of a thyroid cancer that's imaged initially with I-131 and then treated. And you can see that the treatment results in the loss of the signal. And then the patient recurs and he's retreated, and the I-131 actually treats the tumor at the same time with radiation. So that's actually possible too. So these days, the SPECT camera, which is seen here as these two jaws, and they sort of turn around the patient, is supplemented with a conventional CT scan. So you get what's known as a SPECT CT scan, where you can see the activity in this lymph node superimposed on the CT scan. So that's SPECT CT. So, of course, radiation is, again, our main concern. We have to protect our workers, the operators, so we have lead-lined syringe holders, and we have to protect the patient. But that leads me to the next kind of more advanced nuclear imaging called positron emission tomography. So remember we said that for a single photon emitter, the gamma ray comes out in a random direction, and it's difficult to predict. With a positron emitter, the nucleus will give off this positron, which is nothing more than a positively charged electron. And when it meets a negatively charged electron, in other words, the normal kind of electron, what happens is something known as annihilation. And this is matter-antimatter. And it may be science fiction sounding, but it's real. The positron will annihilate the electron, and the result of that will be two gamma rays setting off in different directions at the exact same energy, 511 kiloelectron volts, keV, in opposite directions. Well, how useful is that? Very useful. Because if you set up a detector array and you hear a ping at one side and a ping at the opposite side at the same time, nearly simultaneous, then you know the event has taken place somewhere along that line. First of all, for every annihilation, you get two gamma rays. So that's much better, well, it's twice as good as the SPECT emitter that only produces one gamma ray per decay. You get two, but you get directionality out of it, because you know that if you're hearing it here and there's one over there, that the event happens somewhere along this line of response. So PET scans are highly sensitive, provide metabolic information, much better spatial resolution than SPECT because of this feature. You don't need to collimate them because you're only going to accept the events that occur simultaneously. So you get much more efficiency with regard to how much radiation the patient has to get to how much imaging you need. So you can lower the dose. You can combine it with CT. It is an expensive toy. It is subject to all the regulatory issues. And the agents we generally deal with have a short half-life, so we need to move relatively quickly. So this is just a depiction of what I just said. So the fluorine-18 emits a positron, and it wanders off, according to how energetic it is, until it encounters an electron where it madly falls in love and annihilates, sort of a quick romance, and 2 gamma rays are emitted. And then we can detect them in opposite parts of the gantry. So there are actually many things you can do with a PET scanner, but the thing we do most commonly is inject this agent, F18 deoxyglucose. Now, in the 1920s, a man named Otto Warburg, a biochemist, discovered that cancers upregulate aerobic glycolysis. So ordinarily, as we sit here with lots of oxygen around us, when we get a glucose molecule, it goes to pyruvate, and then it enters the Krebs cycle, and we generate lots of ATP. Cancers take a different approach. No matter how much oxygen there is, they convert pyruvate to lactate. It's called aerobic glycolysis. Ordinarily, that only occurs when there's no oxygen, anaerobic glycolysis. But tumors switch it on, so there's aerobic glycolysis. And as a result, because it's a very inefficient kind of system, you need lots of glucose to run a cancer. The cancer gets other things out of it. We don't need to talk about that. But Warburg was the first to describe this phenomenon. And Lou Sokolov, who was a scientist here at the NIH, who unfortunately recently passed away, was among the first to recognize that the deoxy form of glucose could get into the cell very much the same way glucose does, but would not be metabolized in the same way, either entering the TCA cycle or converted into pyruvate, but rather under the hexokinase was converted to FDG6P, G6P, glucose 6-phosphate. But the deoxy, the lack of an oxygen on the glucose, prevented it from going further. So what it did was accumulate in cells that were bringing in a lot of glucose, like cancer cells. So suddenly, you had a very cute way of figuring out what was a metabolically active tissue from one that was just normally active using FDG. Now, it took quite a lot of time to figure out how to practically label this with the PET emitter, F18, but it was done. But we owe Lou Sokolov the insight that that was an important thing to do. So we can use it in common imaging. For instance, this is a patient, this is his bladder with a Foley catheter in it, but this is a very small lesion that could only be detected with the FDG PET scan. And it's just this small molecule with a F18 on it that comes in through the GLUT1 transporter and is converted to the phosphorylated version, but goes no further down the metabolic chain. So it's stuck inside the cell. So we have the positron emission tomography device that produces an image like this, very kind of, compared to CT and MRI, not highly spatially nice, but we can combine it with a CT and get this fusion image where we can get the anatomy from the CT and the function from the PET. And so we do this a lot. This is an example of a patient with breast cancer, and you can see the activity in the anterior mediastinum, activity in the spine, and so forth. Now, there are lots of different PET agents that can be used. FDG is the most common, but we can use sodium fluoride, which is a bone-targeting agent, fluorothymidine for cellular proliferation, estradiol for estrogen receptor, fluorocholine, fluoromiso for hypoxia, for amyloid for Alzheimer's disease, for labeling antibodies and cells. And so it's a very, very powerful technique. It has high sensitivity, very high sensitivity among all the devices that I've talked about. It's the most sensitive. And but it, of course, still requires some degree of radiation. So I want to summarize what I've said to you. This is the order in which I presented the radiology department to you. It's a virtual tour of the radiology department. In terms of resolution, the top of the heap is CT, followed by MRI, then ultrasound, then PET, then SPECT. That's the least ability to resolve two structures. In terms of sensitivity, however, PET clearly towers over all the other techniques, followed by SPECT, ultrasound, MRI, and CT is the least sensitive in terms of molar concentration that you could detect. So we have to put in grams of iodine into a patient to even see it on a CT scanner, whereas I'm putting on the order of nanomolar concentrations of FDG into a patient to see that. So the sensitivity is many, many orders of magnitude. And then cost, well, ultrasound is clearly the cheapest. CT, SPECT, MRI, and PET is the most expensive. So you can see how different healthcare systems might apportion how much scanning is done with various devices. If you're a country that's very wealthy, PET is something that you can put on the table. If you're a country that's very poor, ultrasound is a device that's used very frequently. Nothing wrong with that, but we know that there's some limitations to what ultrasound can do. So hopefully, with time, as time goes on, more people will have access to all these kinds of devices. So just as a generalization, and just to wrap it up, CT is our workhorse in oncology. MRI is used for specialty cancers like the brain, liver, and prostate. Ultrasound is a very important technique for problem-solving specific things like, is it a cyst, is it solid? For looking for bone metastases, the SPECT scan is still premier. And for any agent that we want to get information about the metabolic nature of a cancer, the PET scanner is the way to go. And if you have think of anything, any questions, feel free to get in touch. That's our website. And thank you for your attention. Any questions?
The imaging that's used with the MRI imaging, did that have the same problem as the CT imaging with allergic reactions?
Yes. The question was, does the gadolinium-based MR contrast agent have the same problem with allergic reactions that the iodinated contrast on CT did? Keep in mind that that's really, even in the iodinated contrast media, that's gone way down. And it's at the same level now between gadolinium and iodine. So there's no increased risk of allergic reaction. There's a question back there?
Yeah, I was just wondering if there's some fundamental reason why ultrasound can't be implemented the same way as the other imaging techniques are, or if it's just some, information problem, or
yeah. So the question is, why couldn't you implement it in the same kind of architecture as the other? Okay, great question. Good question. First problem. Ultrasound doesn't go through air. It reflects right off the air. So like if you try to scan a lung, can't see it. Sound just comes right back. So if you put a gantry with an ultrasound transducer over the patient, you wouldn't see anything. But let's say you could bring it down to the patient and then sort of slide it around. You could do that. Here's the next problem with ultrasound. It doesn't penetrate as far. It only goes, it's related to the frequency of the transducer. So the lower the frequency, the more it'll transmit. But the problem with that is the lower is the resolution. Whereas if you go to higher frequency, it won't transmit very deep, but you'll get exquisite images of the stuff close to you. So people have actually designed scanners based on ultrasound in the same sort of architecture, but for specialty purposes like breast ultrasound, where the transducer would go around the breast. Really hasn't caught on that much. It's expensive, and one of the beauties of ultrasound is you can take the probe, put it where you need it, see what you need to see, and be done. So the simplicity of it is its virtue. And of course now you can put it in your pocket and do that anywhere in the hospital. So cool. Anything else? Yeah.
I know functional MRIs have like a merge. Would that give greater resolution than like a PET scan?
Okay, so really good question. The question is, there are functional MRI scans, mainly used in the brain, and could that supplement or even replace PET scans? Good question. So how fMRI works is it depends on very subtle differences in oxygenation of hemoglobin between the activated state and the unactivated state. So it turns out if you're asked to do this, there's a certain part of your brain that gets activated, and there's increased blood flow, and it delivers more oxygenated blood than was there before. And if you scan enough in a certain way, you can detect that 1 to 2 to 3%, max 3%, 1 to 2% change and see it. But what it's reflecting is change in blood flow. What the PET is saying is there's a change in glucose metabolism or something else. For instance, if you're looking at dopamine, it will say, yeah, there's more dopamine when you do this. So they're really two different things. The beauty of the MRI is that there's no radiation, no injection. It's, these paradigms have enabled us to see when people are lying. When you lie, there's a lot of blood flow increase in your brain. When you're telling the truth, it's very quiet. And, honestly, people are using it in all kinds of ways. And it's very, it's very applicable. Psychology departments now have them just to do experiments with. Whereas PET is so much more complicated. So it's not really apples and, apples. They're different. They tell you different things. But certainly the fMRI has been extremely useful. Do I have time for one quick story? Right. One quick about, they were very, there are all kinds of ridiculous paradigms, but one of them was, what goes through people's mind when they're thinking about taking a golf shot, playing golf? So they took amateurs and professionals, and they showed them a picture of a scene, and they please imagine yourself hitting the golf ball to the green. And so the amateurs, there was like no pattern. It was all over the place. The brains lit up. And with the professionals, nothing. They didn't even think about it. It wasn't, there was no added effort. So it's just, that's not to say professional golfers are empty-headed. I think they're very brilliant. Yeah.
Compared the MRI to PET, but how about the other quantitative MR methods, like even MT scan, DC, getting APC value from a diffusion rated, and things like that? Most of them are not used, but eventually they're moving for getting more information of the tumors that would help.
Absolutely. No, I'm a big enthusiast. I do MRI, and we do multi-parametric MRI. Some of the things you just mentioned, diffusion weighting, T1, T2, MT, magnetization transfer. These are all things that they're actually not subject to FDA approval. You don't need approval to use them. And they provide, added information over, say, CT scan. And they're in the functional class of MRI. So it's a little confusing because the term fMRI applies to brains. That's the term of art. But in fact, the techniques that you're talking about are also functional in the sense that they're not purely anatomic. So let's just take diffusion, because I don't know if everybody understands what we're talking about here, but diffusion weighting. So water moves in the body. It moves everywhere, but inside the body there's a diffusion of water. You can apply gradients and see how fast that water moves. And it turns out in tumors, the water is restricted. It can't move very much because there are all these cell membranes, so the water moves a little, bumps into a membrane, bounces off. It's like tight. Whereas in normal tissues, it's more relaxed, so the water can flow. And so you can actually measure that difference as a diffusion coefficient. And that tells you, that's actually, turns out, in the case of, say, prostate cancer, the lower the diffusion constant, the higher the grade of the cancer, the worse the cancer. It's amazing. It's totally non-invasive, but it gives you some, indication of that. Anyway, our time is, we have to close, but I thank you very much. Have a good evening.